think I need to
As part of our continuing series of expert interviews on the NKDO YouTube channel, our guest today is Dr. John Friedman, Chief Medical Officer for Transplant Genomics, also known as TGI. TGI is a personalized diagnostics company whose tests improve organ transplant outcomes by detecting early signs of graft injury. By differentiating among the actionable causes for the injury, TGI's suite of tests seeks to enable the most optimal therapy, as well as diagnoses and prediction of transplant recipient immune status. Prior to joining TGI in January of this year, Dr. Friedman had a 30-year history in helping patients with chronic and end-stage renal disease and other complex medical conditions. He was a co-founder of United Health Group's HERO, Helping Employees Receive Organs program, which paid lost wages as well as travel and lodging costs to people who donate a kidney to a UHG employee. Dr. Friedman was awarded fellowship honors by the American Society of Transplantation and received an AST Distinguished Service Award for his dedication to living donors. Prior to joining TGI, Dr. Friedman was the Chief Medical Officer for Optum's Medical Benefit Management Programs. Dr. Friedman, thank you for joining us. I'd like to start by asking you to describe your role as a Chief Medical Officer for a therapeutics company and how that role both differs from and may be similar to the role of a medical professional working in a hospital or private practice.
First, Ned, let me thank you for this opportunity to address your audience. When I met you in Boston at the American Transplant Congress, I was immediately impressed by your organization's dedication to support living donors. It's right up my alley. Living donors just don't get the respect they deserve. They are truly heroes, donating a priceless asset to their recipients. And that was the impetus behind the United Health Group HERO program, that no living donor should have a financial burden associated with their donation. And navigating the healthcare system is no easy task, and that's a lot where you come in. If I may take this opportunity to plug the American Society of Transplantation's Corporate Circle of Excellence for Living Donation, which highlights companies in North America that support their employees by paying lost wages to them if they are the donor, or directly to their donors who donate to the employee. Eurofins and TGI are part of that circle, and I am currently a member of their governing council. So anyone listening to this broadcast, please Google search the AST Living Donor Circle of Excellence and get your employer to sign up if they aren't already part of it. But back to your question. When I was in private practice, I had a panel of about 2,500 people, both commercial and Medicare, mostly chronic conditions like diabetes, hypertension, osteoarthritis, and the such. And I can only think of a few cases where I actually saved a life. But when I went to work for Pacificare, a health plan 20 years ago, I was overseeing their care management division in California. And through a series of events, was asked to develop their national transplant network. That was a very eye-opening experience. I knew very little about transplantation at the time, but transplant surgeons and physicians just love to teach. At the time, we were covering about 4 million lives, and I was tasked with developing a network to help the sickest of the sick, because without a transplant, these people die. And getting them the highest quality care was paramount, and thus the development of a world-class Centers of Excellence program. And I consider end-stage renal disease a terminal disease, even with dialysis. There is a 55% 5-year mortality associated with dialysis. It is life-prolonging, but not life-saving. This population must get transplanted. So we were saving a bunch of lives, getting people transplanted. When Pacificare got acquired by United Health Group in 2006, I began to oversee the Optum transplant network. And now we had responsibility for 20 million lives. And having the best Centers of Excellence program was imperative for the best possible outcomes for these desperate people. So now I've moved on to transplant genomics, a company, in my opinion, has the best biomarkers on the market for the early detection of subclinical rejection in transplanted kidney grafts, both T-cell mediated and antibody-mediated rejection. It is a more focused, targeted audience, you might say. They have already been transplanted, gone through the ordeal, hopefully received a living donor graft, or waited out the wait list and have now finally gotten their priceless gift. But how can we maximize the life of the graft, either from a living donor or a deceased donor? The answer is through the earliest possible detection of subacute rejection. Repeated episodes of subacute rejection, if left untreated, leads to chronic inflammation and then fibrosis. That is technically called IFTA, which is interstitial fibrosis with tubular atrophy, and eventually leads to premature graft loss. No donor donates a kidney with the thought of, gee, I hope my donation only lasts 2 to 5 years. This is another way to honor and respect the donors by prolonging the life of these precious gifts, the grafts, to maximize the longevity of the graft with a goal of one transplant for life. So at every level I've advanced to, I've gotten more focused on the sickest of the sick population, and now hope to help those who have made it this far to never have to go through this process again. But let me make it clear, I have the utmost respect for all of the practitioners out there at every level who still provide direct care to patients, because without them, healthcare doesn't exist.
Thank you for that. You have a background in dealing with complex medical conditions, and we know that chronic renal disease can initiate a perfect storm of ailments that might create myriad complications. Can you give us some insight into how a person without a medical background might better understand the cascade of medical events that one might expect with renal failure?
Sure. So renal disease has frequently been referred to as the silent killer. 1 in 7 Americans have chronic kidney disease, and most don't know about it. The vast majority of chronic kidney disease is caused by hypertension and diabetes, silent diseases, or caused by immunologic causes that are also relatively silent. And upwards of 80% of people have no clue they have chronic kidney disease until they begin to feel the symptoms, which are fatigue, drowsiness, decrease in urination or inability to urinate at all, dry skin, itching skin, headaches, weight loss, nausea, bone pain, skin and nail changes, and easy bruising. They often show up to their doctor in the emergency room where they'll get a blood test that'll show that they are in florid renal failure. I was talking with a health plan in the South that says 80% of patients start dialysis in the emergency room, undiagnosed. It's tragic. And at that point, the cat is out of the bag. If you don't catch it early enough, there's no hope of preventing further deterioration. The true greatest thing ever would be to get people referred for a preemptive living donor transplant. If you can get a preemptive living donor transplant, your graft will last on average 15 to 20 years, meaning many will last longer. A deceased donor transplant lasts on average 7 to 10 years. So you're doubling the natural life of the graft with a preemptive living donor transplant. So it's really worth seeing your primary care physician on a yearly basis and getting those routine blood tests where the signs of early chronic kidney disease may show up, and there's hope of preventing the progression, avoiding the transplant altogether. Quite frankly, the best transplant is no transplant. It's curing one problem, but creating another one, which we'll talk about in a little bit. But clearly, early detection and diagnosis is key.
Great, thank you. So if my understanding is correct, TGI's suite of diagnostics is intended to identify a condition before it can do lasting damage, and to do so in a way that is far less invasive than the traditional biopsies that seek to determine causes and levels of graft impairment. Please tell us about some of the tests and how they work. Are these tools only used when rejection is suspected, or are they part of ongoing maintenance therapy for transplant recipients?
That's a fabulous question, Ned. So for years, the gold standard for early detection of subclinical rejection was surveillance biopsies. But we know with an incidence of about 25% of rejection in the first year, that 3/4 of those tests, 75% of those biopsies will be negative by definition, and therefore probably unnecessary. These biopsies are invasive, expensive, and not without risk of complications such as bleeding or even graft loss. Most programs do biopsies for cause, when the blood or urine detects potential kidney injury. The problem here is by the time your serum creatinine, the marker of kidney function, goes up, there is already significant and irreversible kidney damage. To get a bump in your serum creatinine usually implies a 30 or more % loss of kidney function. Kidneys do not regenerate like livers do. So the goal is to detect possible rejection before the injury occurs and also potentially avoid biopsies altogether. We like to call this bump the biopsy. It's a marketing term. Our biomarker Omnograph, which is a combination of a gene expression panel and a donor-derived cell-free DNA component. The gene expression panel by itself is called TrueGraph. The cell-free DNA component is called TRAC, and together they're called Omnograph. The gene expression panel can detect immune activation before cellular damage has occurred. It gives you the ability to treat before you have damage to the graft. The donor-derived cell-free DNA component, as you might expect by its very name, detects the DNA from the donor circulating in the recipient's blood, and this only occurs after cellular damage has occurred. So the gene expression is much better at detecting T-cell mediated rejection, which eventually leads to the antibody-mediated rejection, which is what is mainly found through the donor-derived cell-free DNA component. Together, these are a powerful tool in the arsenal to protect kidney grafts. Together, with Omnograph, there is an 89% positive predictive value that there is something going on if both tests are positive, and a 94% negative predictive value if both tests are negative. There are other tests on the market that only use donor-derived cell-free DNA. Their positive predictive value is only, on average, about 55%, which is only slightly better than flipping a quarter. The two tests are one blood draw and have a better detection of subclinical rejection. We like to call it the power of one.
Okay, thank you for that. So besides transplant centers, who else employs your diagnostics? Nephrologists in private practice and general practitioners, perhaps?
So you're right that biomarkers are mostly used by transplant centers on the patients they're following after transplant. But it is our hope, with appropriate training and education, and you know all about training and education, that community-based nephrologists who often take back the care of the patients will become comfortable using Omnograph to help guide treatment of those patients for the long term and lead to better long-term outcomes. It is not unheard of for someone who has gone along for 4, 5, 7, 8 years with no rejection to all of a sudden have an episode of subacute rejection. Exactly how these should be used in the long run is still to be determined, but we feel that the more people that have the education and training, the better for the long-term outcome of the grafts.
Okay. What aspect of diagnostics are the most challenging for you? What are some of the shortcomings which your tests face at present, and how do you hope to overcome them?
We know we're not perfect, but we truly believe we are still the best biomarker currently available on the market for detecting subacute rejection. We are continuously striving to improve. we significantly improved our detection rate when we went from something called microarray assays to PCR assays, which are polymerase chain reaction. Our next generation of gene expression will have a positive predictive value of 90% and a negative predictive value of 98%. And that's by itself not needing the assistance of the cell-free DNA component. And with accuracy like that, we believe you can truly bump the biopsy and initiate therapies without the invasive confirmatory biopsies. We are continuously striving to achieve better results that result in longer graft life and ultimately lower the total cost of care, which is what we believe is driving value.
Okay. Now, so it seems to me as a non-medical layman that the transplant industry is in a constant struggle to balance the suppression of the immune system so that the graft will not be rejected with the need for an immune system that can ward off opportunistic infections and various cancers. There are several companies approaching this problem with different potential solutions. As a diagnostics company, you may be less interested in which approach is the best one than in helping each player as they work to improve their own diagnostics towards a solution. But as a medical professional with a broad view of the landscape, I'm curious as to where you think the industry will find the ultimate prize of a graft free from the threat of rejection.
Ned, for years, the quest for the holy grail in transplantation is to achieve tolerance, where the body no longer sees the graft as foreign, but as self. Many have tried, and some are perhaps getting closer, but again, will it be 100% effective and accurate? In addition to detecting subclinical rejection, we believe Omnigraft, particularly the gene expression component, allows clinicians to reduce immunosuppression medications to their lowest possible effective level. Over-immunosuppression leads to infection, worsening renal function. Here you are, just as you said, you're balancing, I got to protect the kidney, but the more immunosuppression, I'm actually hurting the kidney. It also leads to malignancies, cardiovascular diseases, and a whole host of other bad things. So the gene expression panel component will allow doctors to know when they've reached the lowest level of immunosuppression that is effective in keeping the kidney quiescent without going too far, because then you'll bounce, the gene expression will turn positive, you go back up on the immunosuppression, the kidney will go quiet again. But the ability to detect this subclinical rejection, I think, is also important for companies who are working to achieve tolerance. How do they know their tolerance is enduring when there's possible subacute rejection breakthrough of the tolerance? So I think we will actually be working with some of these companies trying to achieve tolerance and improving their long-term viability.
Okay, so what questions have I not asked that I should have asked? Is there any observation you would care to add at this point?
You know, I think we've covered a lot without getting too technical about the science, which sometimes is pretty baffling to me. And we have a very strong research and development department. But I do want to take this opportunity to once again emphasize the importance of organizations like the National Kidney Donor Organization, who help to educate prospective living donors so they can donate as safely as possible. We'll never clear the kidney wait list with just trying to increase deceased donors. We will need more living donors who understand the process and won't have financial barriers. And hopefully they will know there are companies out there like mine who want to keep their donated grafts functioning for the natural life of the recipient. Ned, I think we are better together.
Dr. Friedman, it's been a pleasure to spend this time with you, and I thank you for joining us. This interview will be up on the NKDO YouTube channel in a few days. Thank you again for your time.
My pleasure, and I look forward to meeting you in person again very soon.